Hello, everyone. I believe that everyone can hear me. And please, all Spanish speakers choose the Spanish option, cancel, and silence the main audio so that we will have Ekawat's and Brian's presentations in English. Can everyone hear me? Perfect. I see Marta, Sylvia, Catania, Sofia, Soledad. All right, everyone can hear me? That's good. Tanya, I can see you twice. So maybe you're on your phone and computer. Perfect. All right, we are going to start. We already are a few minutes behind. We don't want to delay too much. The rest of our friends, mainly Ekawat, who is one day ahead of us, very early in his country, and Brian, it's very late for him, and mainly for Cesar and for everyone's schedules. It's a pleasure to be with you. Thank you for this moment so that we can get together and to be in this webinar internationally at the uh, coalition. Thank you to Andres, Isidro, Lucia, who is acting as our interpreter, and everyone who collaborates with our actions as well. I only want to mention that in the coalition, we always do this sort of activities in specific dates. We try to reach through different subjects, and we are focusing on a slogan for women and girls who had bleeding disorders, and that we will that we will speak on Wednesday. But we also want to speak more about the situation, the data, and access to registries in a global level. What happens in our region, which we already know the situation of, and what happens in the rest of the world. That's why I thank you, all our speakers today, for their time. And the idea is that they present their, they do their presentation about 15, 20 minutes, and then we can move on to questions that I'm sure that there will be. First, I want to give the microphone to Ekawat Suwantaroj, who is a patient with severe hemophilia A. He is from Thailand, and he is a member of the executive committee of the World Federation. He's going to talk about data and registry, and he's going to give us a overview of the region. Thank you, Ekawat. I know that's very early, so you have the floor now, and we will continue with the other speakers. Thank you.
So, hello everyone. Thank you for having me today to present the Thailand about the access and registration. And I have my slides. Sure. Okay, and just to update that the earthquake is fine now. I'm safe. And everything get back to normal, mostly. So to just give you the overall that we working globally with the World Federation of Hemophilia. So now we have a regional group as the ASEAN Hemophilia Networks. So as a 10 country in Southeast Asia, we get together for a number of years and get support from WFH as well. For the national level, so patient organization is under the National Hemophilia Foundation of Thailand, which is the main NMO registered with the government. We have an ISTC in Bangkok. We Thailand have a universal health coverage. Hemophilia was one of the high-cost disease under this program. So that means every child with hemophilia in Thailand can get the factors from the government with the limit budget. And we have Social Security Office. There's a program for the person with the uh, get employed and work. So they have to go to this program, which is now a different benefit from the universal health coverage. So we have 5 regional chapters so far. Uh, this is quite challenge from low middle income country in terms of registrations. And now today with the PDPA, the private data privacy, um, is even more for the patient organization to get information from the healthcare provider, hospital people to send us the data. They're afraid about the data privacies. We also work closely with the Thai Red Cross and the main hospitals in Thailand. Now we have a 50 hemophilia treatment center in Bangkok. Some center is not really active, but they can handle with the patient when they have the emergency cares. The doctor train each other to develop the comprehensive care in all over the 50 treatment centers. Uh, so this kind of story of the patient engagement and how we get into the universal health coverage program, and we develop the data registration program all the way 20 years to find more options for the patients and the center to report the data to the center. We started 2000. We patient and family get together, just prepare for the Congress in 2004. Dr. Patalaporn, she's the one that is the leader of the NMO by that time. And she asking the family to get together. And the one thing that the common goal that we try to pursue is try to switch from cryoprecipitate to the factor concentrates. So that's the main pain point that we try to work with the government to get the safety product, and all the country can access to these medications. 2002 is the year that we exhibit the Thai Hemophilia Patient Cup. We try to uh, spread out across the country to announce that we have the patient organization, get the data collection, the membership program. And the first camp is right after that. And we promote the camp all over the regions. Uh, the reason is the camp is do the social awareness and prepare the family and the patient for the home treatment. So every camp we try to get the data. Also, we teach them how to do the home care. One of them is the cell infusion. Even now, we still teaching the cell infusion for the patient and families. Until the 2004 World Congress in Bangkok, that's the big shame because we have the big event in Thailand, and the royal family came over for the open ceremony. Right after that, the government has opened the door for our NMO and the patient to meet up and set up the program for hemophilia. So 2010 is the year that we get through the universal health coverage program. The data is not quite fully uh, support in terms of the number of the patients. But we think it's start with the low number is better than with the big number of the patients, because the government uh, kind of afraid about the budget of hemophilia too. So the first time that we get through, we have only 2 vial of 500 IU per month at the beginning of the program. And the registration with just 1,000 patients all over the countries. But the good thing is the government increased the budget every year, and the data registration is slightly increased every year. Uh, Not only the home treatment the government provide to us, they provide the emergency budget in case that you have to go to the ER, and also the light treatment in case of the you have to use the big amount of the factors. So we can use the different budget to cover these situations. So the challenge that we facing is, of course, registration. Now, over 20 years, we still very behind of estimate of the patient with hemophilia in Thailand. We have around 2,500 patients listed, and the estimate is around 5,000 or 6,000 uh, patients with hemophilia. Uh, so the education is still the thing that we try to work with the patient, with the family, because the innovation change, and now we got better treatment. The prophylaxis is the one that we talk with the government, and the government kind of agree to have the prophylaxis program with the kid under 10 years old. Now the government open for the standard dose for the kid. That for adult with the target joy is still a challenge. And for the imicizumab, the government might start with the small population of the patient with inhibitor only. So we collect the data for all over the treatment center in Thailand, and it start with 150 patients with inhibitor, mostly the kid, to get through imicizumab program with the low dose imicizumab. The Dr. Ampaiwan in Thailand set up this program and apply to the government. So we're waiting for the government to say it is good to go for the next 2 years for this group of patients with inhibitor. So during the COVID, the show up the self-infusion is still the mainly issue for our patients. Some of the patient and family cannot handle the self-infusion. They still have to carry the factor to the clinic or the hospital. So we, after the COVID, so we bring up this program, the camp, to more focus on the self-infusions. And of course, with the limited resources like low middle income country, we have to use alternative way to help to use the factors. So the weight control is the one that we try to encourage the patient to do some exercise and more control with the food, everything to try to do the weight controls. And we just have the the document about the 5 decades of successive exhibits of hemophilia care in Thailand from Dr. Ampaiwan. That now is fully article is available in Thailand and Francis. And you can see that from the first steps to right now that we try to get to imicizumab. Every step we take so much time, and with this working with the patient and the doctors closely, and come up with a strategic plan for each steps. Just right now that we took so much time to come up with the strategic plan with the imicizumab and try to introduce this prophylaxis program with the government, because at the beginning of the the program, the government is not buying the idea of prevention. They think it's a high cost product like this is to use with the on-demand treatment. So we have to show the data, not only in Thailand, also the global data that prophylaxis program may be the better for the quality of life and also can save cost of the uh, budget from the government. So the data from the World Federation of Hemophilia is very useful uh, to compare because in Thailand, sometimes it's difficult to do the research only in Thailand. And it's gonna take so much time to come up with the data to show to the government. So this is the benefits of how we do the global survey and how we can use the data from the World Federation of Hemophilia. And thank you for your attention and happy to answer the question if you have.
Thank you, Ekawat, for your time. Thank you for what you mentioned, what you showed about the status in Thailand. Thank you, and we are waiting for any questions that we may have. I want to give Cesar Garrido the floor. We probably all know about him. He's a great friend, a previous coordinator for the coalition, and the president for the Global Federation of Hemophilia. Thank you, Antonio. That hopefully we can all see it. Well, Ekawat, thank you. It's an important story that the one you're telling. I have seen how things have changed in Thailand. I want to show the importance of data as a tool for us to be advocates. And maybe it's something that you use, but you don't realize the impact of what we do with the data. Treatment for all is a saying that we have used a lot of times and we have heard it. It's a common problem that we have. It's a project that we have. If we all collaborate, sending the information, sharing the information, sharing our expertise, it's easier to get to reach the treatments that we need. That's our main goal. The current outlook, this numbers unfortunately have not changed. Somehow they still the same. They're still the same. More than 75% of the approximately people living with hemophilia are undiagnosed. Those who are diagnosed don't have access to treatment. You have already heard all of this, but this doesn't mean that we don't have to find a solution to achieve these objectives so that these numbers disappear. We are not going to abandon these efforts. We need to reinvent ourselves. We need to make ourselves more effective with our data. We need to be more expressive. In here, you can see three pillars when it comes to treatment for the WFH. The three pillars, we are going to revise them soon again. This is a huge cornerstone for the WFH. Ekawat already mentioned the role of prophylaxis during his presentation. It becomes a universal need without limitation to the criteria of the hematologist. The prophylaxis is the standard treatment for a person with hemophilia. The humanitarian aid has also allowed us to take medication to regions that before had none of it. And thanks to that, medication, thanks to the capacitation of professionals. We have able to uh, gain data that has been very significant in letting us know what do we need to improve, how are we moving forward, and data. Data itself, the management of it, it's key. That scientific evidence, so that we can create advocacy, so that we can show our governments what do we need to do. The annual global survey has already been established for 23 years old. We are always running 1 year behind. And the annual global survey has been the tool that has allowed us to reach the point where we are now. It has its weaknesses. It has its lack of data sometimes. And it depends from where the origin of the data comes from. The annual global survey has all the national organizations sending all the information. Sometimes they don't send it 1 year, or they don't think that they have enough data, or sometimes they're considering, should we send this information or not? Sometimes the health organizations send it, sometimes others take care of it. But the need for information sometimes shows this fluctuation in the charts. Doesn't mean that a lot of people died or people were born. It's just the information that we receive. To show scientific strength to this information of the annual global survey, how many people do we have with hemophilia? How many have hemophilia type A or B or von Willebrand? It has become more sophisticated to the point that the people who fill out the survey fear that they are going to fill out the survey with the wrong information or with false information, or they don't understand the question. And I ask you, if that's the case, please ask your regional managers, and we can try to uh, give you some support regarding this. It's important to send the information in a timely manner from any of the organizations that are involved in this. We need to give them a scientific, more palpable details. So with the federation, we created the WBDR, the World Bleeding Disorder Registry. From the 2018 to today, we have 127 HTCs that are shown in here on the map all throughout the world. They send information, clinical information for the patient with no names. It's completely confidential. The patient is just a code, a number. About 15,000 patients with hemophilia, and a lot more with one the brand. This has allowed us to reach conclusions like diagnosis in America. It's usually 1 or 2 months after the person is born, after the baby is born. And in the Southeast Asia, we have a 1 year or 2 year diagnosis, which allows the federation and the organizations like Ekawat mentioned for Thailand, so that they can go to the authorities and say, hey, we have a preventive diagnosis. We need to diagnose this earlier. We need to prevent bleeding. So that's why the survey, the WBDR, there are tools that will allow you to present evidence to the authorities to show which data, which investment, what should they pay attention to. We also need to different sort of registries for physical therapy that is not as widely known, but it's also very important. So how do we reach that information that you're seeing here? We need to see beyond the numbers. We have almost 1 million people with hemophilia and other bleeding disorders. That way, we can give you these charts where one can interpret, for example, we see an increase of von Willebrand, but in the bars, it's almost the same size. These are percentages when that we see yearly, and it's important that we see an increase the more we continue. How come if we are advancing, how do we see all this lack of diagnosis? Well, the rate of population increase also plays a role. In here, we can see different regions. For example, Europe is one of something that Brian may mention later. Of course, in Europe, with developed countries and countries that are still being developed, but Brian will keep me honest. And a lot of these countries manage data. They use the data that comes from local organizations, and it has allowed them um, a more precise action plan. That's why they are spearheading this percentage right now. In Americas, we're talking about North America, Central America, South America. We are only at 57%. In the last 3-4 years, we have seen an increase. But I think that we can have a bigger increase. We still need that jump when it comes to diagnosis, when it comes to information. We have countries that we don't know a certain information. Why is it not growing? Why are we still working with 52, 53%? So these countries need to emphasize new formulas, new ways to interpret data so that you have an image of how things are divided. You can see, for example, Europe, only 10% is Europe, but see the consumption of factor 8 that we have. That paradox in hemophilia, it's quite common. It's curious, but it's very dramatic since most of the population is in Southeast Asia, but on the consumption of it for the units, for factor 8 units, it's the lowest percentage. These are things that shouldn't frustrate us and shouldn't make us passive. It should make us focus more. With the Federation, we're trying to find formulas to change this. It's a huge challenge, but since Ekawat is part of our team, I think it's a huge human tool for us to advance even more. In here, I'm going to show you the global charts where you can see the amount of people versus the um, units of factor 8s that are being consumed. On the red line, you can see this variation. It all depends for budget and the budgets that the different governments have. And I want you to check on the blue line. On 2022, there was so many people above the 200,000, and now you see a decline. Don't think that these patients are no longer with us, except that a a country with a huge population, maybe they don't report to the survey. They just didn't give us the information in a timely manner. Sorry, there's someone with the open microphone, and you can see these variables that are quite jarring. But right now we're going to move to the Americas. We have seen a lot of decrease from 2018, the acquisition of factor 8. But we have seen a tendency that has matched when it comes to the increase of diagnosis from 54 to 57%. So the lines are uh, growing more distant between each other. We don't have specific conclusions. One may be that after the pandemic, the budgets for the health organizations changed. For example, hemophilia was a star, a weird disease. Now, the situation is not the same when it comes to data. The emicizumab presence may have caused an impact as well. But it's one of the many explanations that we cannot be satisfied with, that we send some information and what happens next? So we're going to go to each country. We're going to see the blue and red lines of each country, and maybe you can speculate and you can draw your conclusions about them. When it comes to Latin America, when I take Brazil out of the chart, there could be a huge variation when it comes to buying and the people person. Tanya, maybe you can tell me a little bit more about the amount of patients. So we have seen an increase when it comes to diagnosis in Brazil in a positive way in the last 2 or 3 years. Brazil is a huge case because the information is sent by the health ministry. They gather the information from different treatment centers that belong to that ministry. And Brazil is very specific when it comes to census data. I didn't take it out due to time constraints, but you can see a huge variable variable when it comes to using Esisumab or any other uh, change that is affecting LATAM. We cannot draw a conclusion because the lines are sort of parallel to each other. The way that the diagnosis increases, the health authorities, because we're not considering humanitarian aid, the organizations have gathered that data thanks to the organization leaders. Right now? Okay, better. So let me go back to my presentation. Sorry for that. My Wi-Fi had a bit of a mishap. In this chart, we can see a lot, and we have to pay attention to it. And we can compare my country to the rest of Latin America or the rest of the world. When it comes to these sort of arguments, we can think maybe if advocacy that we have been trying to foster, is it generating an effect, or should we change the argument? Should we change the formula for advocacy? So we have the general chart. I think that this is very important. This is the amount of years that the different countries have been reporting on. I don't want to discredit Trinidad and Tobago with 4 years, but of course, it cannot be the same that we have the information for 4 years, that we have an information for 24, 25 years. We have a lot of more time knowledge about what's going on that we can assert when in comparison when we have such short amount of information. That's the importance of the global survey. Some people have underestimated it or think that it's not as effective, but that's where we get most of our information. The percentage of identified people, when we check in Europe, they have a huge percentage of diagnosed patients, uh, of consumption rates. And you can see in Latin America, they are parallel. So if we are able to register and diagnose more patients till the moment, we have seen a similar reaction. This does not have to maintain itself. Things change, the markets change, but we can still work with this. The percentages speak for themselves. And when we go to consumption, we go back. We go to the case of Venezuela because it's such a specific case. It's one of the biggest cases with diagnosis, but the buying of the medication is one of the lowest. So something that is due to the political status, to the how the health is being handled and how to navigate through these situations of patients. When it comes to Colombia, Brazil, Chile, these are numbers that show us that we can get a bigger amount of medication, and we can try to attend to the treatment lines for prophylaxis. So here you can see the numbers, the hard numbers that we have been able to get for humanitarian aid. So for advocacy, for the sponsors of the program, it's important that we show them this information. For the general public, it's also important that uh, our donations have reached 103 countries, that we have more than 2 billion um, donations have been distributed. For the people who support these programs, these numbers are the ones that interest them. For the people who do donations, they want to know how many people have been treated thanks to their support for any sort of company that they have participated. How many people are using prophylaxis? How many treatments or acute bleedings have been treated? So we have the KPIs. You will hear that a lot of times. KPI, these are indicators that are very visual, that are very tangible, very specific. How many surgeries have we been able to do thanks to this aid? So how many lives have been saved through them? These are, this is why we handle so many numbers, so that we can um, create a proper advocacy. It's not only for a government or someone who pays. It could be for stakeholders, that could be the companies that support the program. So to close out, I have the uh, PACT program, so that we wanted to identify new people with hemophilia from 2021 to 2025. And we have found 27,000 new people that has been diagnosed. We have new patients throughout the world. So if we were talking about advocacy with the PACT program, From when we started to now, it's huge. I want to I want the decisions makers to know that citizens have rights as patients, citizens, humans, that they have a right to health. That's not what we're discussing. What we're discussing is how much it does prophylaxis cost, how much not having prophylaxis costs. How many beds do I need for patients today? Right now, we may not have beds. Uh, for example, thanks to prophylaxis, we wouldn't need to hospitalize patients. That's something that I need you to start thinking on so that you can improve your advocacy. If someone wants any support or any suggestions, you can contact me, no problem. And that's would be me. All right, thank you, Cesar. Thank you, always on the dot. Thank you for your time and for your presentation for all the numbers of America. I would like to give the floor to our third panelist, Brian Mahoney, who only wants to be presented as the Irish Hemophilia Society. Um, and most of you know him, but he was the president of the World Federation. So he knows his stuff and his visions are very interesting. So thank you, Brian. I know that it's night already, so thank you, and we'll listen eagerly.
Sorry, I was on mute. Buenas noches. Es un placer para mí estar aquí con mis amigas de la coalición. It's lovely to see you all as we come towards World Hemophilia Day. I've just put together some thoughts on challenges in access and treatment. I'm not specifically looking at Europe, but I will mention it. And again, I fully agree with what Cesar said. I find the annual global survey absolutely invaluable. I keep a copy on my desk all the time. I keep a copy at home. I'm constantly referring to it. I use it in advocacy because unless you can compare your own data with that of other countries in your region and globally, you can't really make a strong case. So, for example, this is the number of observed versus expected hemophilia patients by region. You can see that Europe has almost diagnosed the expected number, whereas Southeast Asia, Africa have significant deficits in that regard. And if we look at factor concentrate use globally, the mean for factor VIII is 2.69. The median is 1.3. And total factor VIII use is 9.4 billion. And with factor 9, the mean is 0.53 and the median is 0.22. And total factor 9 use is 1.7 billion. Now, two things. One, the impact of emicizumab is not apparent there. The factor VIII use would be much higher if emicizumab was not on the market. So factor VIII use is lower because of emicizumab. And secondly, look at the difference between the mean and the median for both factor VIII and factor 9. And that tells you when the median is 1.3, the mean is 2.69. That tells you there are a significant number of countries using a lot of factor VIII, but a lot of others using much less. So there's a big differential. And if we look at factor VIII use in the Americas, as Cesar showed, you can see vast differences from country to country. And if you look at the broken lines here, that is extended half-life factor VIII. But again, this no longer tells the full story. And I think next year, I understand WFH will also be adding in a third bar for emicizumab, because now you have to look at emicizumab as well. So you can see vast differences from country to country. Similarly, if you look at Europe, you're seeing vast differences. In my own country, Ireland, you're seeing 4.75 IU of EHL factor 8, but in fact, when you add in emicizumab, our per capita use equivalent is 15.2. So we've got extremely high factor 8 use, but the fact is about 75% of our factor 8 patients are now on emicizumab. Similarly, with factor 9, in Latin America, you're seeing big differences from country to country. And in Europe, again, big differences. Uh, Again, if I look at Ireland, we have 2.3 IU per capita, which is very high for factor 9 because it's all EHL factor 9 that we use. Lithuania there looks quite strange, but I'm not sure if Lithuania have actually reported the right number. It's very difficult to see a country using 4.2 IU per capita, even of standard factor 8. And this is one of the points that Cesar made. Yes, it's really important that NMOs report the data, but it's also important that they double check the data to make sure it's accurate before they submit it. So in terms of, we've got this huge disparity in access and treatment. And why is that? Well, I think you've got a difference in resources available and resources applied, and you've got differences in organisation and differences in advocacy. And it's not just a question of resources, it's not just a question of money, because if it was, then haemophilia care, there'd be a straight line graph. If you graphed factor use against GDP, you'd see a straight line. You don't see that. So it's a question of resources. It's about how you apply and use those resources. And it's also a question of organization. And in terms of organization, some of the key points are what is the priority of haemophilia in the healthcare system? Is it even visible? Did the ministry have any knowledge or interest in haemophilia? And that's work that's done jointly by the clinicians, by the haemophilia organization in terms of making haemophilia visible. And of course, one of the arguments you can always use is that there are 7 or 8,000 rare diseases. But haemophilia is a rare disease which, without treatment, leads to crippling, arthropathy, and early death. With treatment, life can be normal. So, unlike most rare diseases, you can treat it successfully. Then, do you have national treatment protocols to give you equity of access around the country? Is there a national register? If you don't have a national register, it's very hard to organize your treatment to predict demand and supply. Is there a network of organized and collaborative centers? That's really important. I was in Japan last year and I was struck. They've got very good haemophilia treatment centers, but I was struck by the fact that they have over 200 centers, some of them with very small numbers of patients. Whereas in our country, it's a small country, we have 4 centers. Is there a strong and active national patient organization? And is there a national organization where it's not split up into a couple of groups, they're not arguing with each other. So a strong national patient organization, key doctors and the centres and the patient organization having influence on policy. And that of course presupposes that the doctors and the patient organizations work synergistically and collaboratively. Because if you have the doctors and the patient organizations going to the health ministry with different objectives, you're not going to get anywhere. So it's important to have doctors involved in policy, having the patient organization involved in policy, and having them work together. And then effective national procurement with doctors and the patient organizations involved. And sometimes health ministries will say, well, you don't really want, certainly you don't want the patient organizations involved in procurement because it will cost us more money. They'll want the best treatments. That is not true. This is a survey we did of 38 European countries and their tender and procurement systems, and we showed definitively and in a statistically significant manner that in countries where the patients and the clinicians are involved, in the light blue here, the prices for all the products across the board were lower. And that's because you're fostering more competition. You're leaving no room for the pharmaceutical companies to come in and drive wedges between the ministry and the patients and the doctors. So this slide, I think, shows you that if the clinicians and the patient organizations are involved, not only do you get better selection criteria and hopefully better products and more treatment, you get lower prices. In terms of resources, well, use the finance available effectively. You know, the as I said, there was no straight line between the amount of money spent on hemophilia and the treatment used. I mean, when I look at data on prices worldwide, I always exclude the USA because they're absolute outliers because they pay much, much higher prices than any other country. So they're not really using finance available effectively. Have effective and cost effective national procurement and national tenders. And that's now actually, through our data, we persuaded the Council of Europe to pass a recommendation saying that national tenders for haemophilia should be undertaken and should always include the National Patient Organisation and the key doctors. If you've got a number of small countries, you could do multi-country procurement. And a good example is Comisca in Central America, where several of the countries get together, they procure effectively as a group. And that means that you're actually buying, rather than Honduras, El Salvador, Nicaragua, Belize buying small amounts of factor, if they purchase it all together, you get a volume discount, you get a much better price. You also get a better analysis of the selection criteria because you have more expertise in the room. Have clear objectives on the treatments required. So look at your resources. Look back at the graph in terms of per capita use of factor. So if you're using 0.5 IU per capita, you maybe you don't necessarily start to think about using EHL factor or emicizumab or gene therapy. Maybe you need to get to 1 IU per capita. And the nice thing is that with the multitude of therapies now on the market, this offers real competition opportunities because you will all realize that when recombinant products came on the market 30 years ago, we were initially told these would be inexpensive and available in large quantities. That did not happen. They were always more expensive than plasma derived until the EHL factors came on the market, and then the price of the recombinant started falling. And now in many countries they're a similar price to plasma derived or even lower. And then the EHLs produce competition between each other, and then emicizumab produced competition with the EHLs, and now we'll see the anti-TFPIs and the rebalancing agents, and maybe gene therapy producing competition with emicizumab. So what's happening is that with all of these new therapies, it's an opportunity to use the latest therapy, but it's also an opportunity to use the finance you have available and the budget you have available to buy the products that are the next step for your country. You don't always need to use the latest treatment, but if you don't have sufficient treatment, you need to use more of it. And actually, the prices have fallen significantly in many countries if they have a good, effective procurement system. And just look at the therapeutic options. This is for factor eight, and this slide is constantly changing. And we now have a multitude of products for factor eight. The latest one added is fitusiran, which was licensed last week in the USA. Now, we've also seen some products stopping. Serpin PC, which was a promising liquor rebalancing agent, has stopped. You'll have seen recently that a couple of gene therapies have stopped and other products have stopped. But there are other products coming down the line, including competitors for emicizumab and for the licensed gene therapy, and hopefully in several years' time, an oral therapy. Similar picture for factor 9. You're seeing you had two gene therapies available for factor 9 now and licensed. Now only one's available. The second one is withdrawn from the market. Marstazimab has just been licensed. And you also have, in addition to gene therapy, you have gene editing and B cell therapy coming down the line. Now look at the prices. So again, when I talk about GDP and prices and the finance available, look at the range of prices here in um, low and medium income, high income, and upper middle income countries. Sorry, that's actually wrong way around. The one on the left should be the high income countries. So, for example, just take emicizumab. In high income countries, the price varies from $15 to $108 per milligram. In LM, low and medium income countries, from 13 to 52, and in upper middle from 39 to 77. So you've got a vast range of prices for the same products. And it's not the case that the high income countries always pay the higher prices. It's frankly, a lot of it depends on the system, on competition, and how you foster competition in the country. And finally, I mean, I think in terms of advocacy, collect and use data to make your case. You may feel very strongly that you want something, but how can you bolster that? What data can you use? What data can you collect proactively? Um, and can you use the AGS data? Can you use data from WFH? Can you use data from other sources? When we switch to a product, we're currently switching people. Everybody who was on EHL Factor 8 is currently being switched to the new ultra extended EHL Factor 8 Ultravoct. But we actually did a quality life survey with them before they switched. We'll repeat it a year later, so we have that data. So you have to proactively thinking about collecting data must become a reflex, must become something you do constantly, and ideally have formal collaborative structures as well for advocacy. And bear in mind that it can be very frustrating, but progress is incremental. Nobody goes from, zero point 0.5 IU per capita to 10 IU per capita overnight. These are steps you take on a journey. Think of it as a set of stairs where you climb each step one at a time. And I'll give you an example of advocacy. These are some of the data. When I was ENC president, we did a survey every 3 years, and we looked at every aspect of comprehensive care in every country. The chart on the top is the same data as published in the papers, but that was produced primarily for health ministries because the health minister will not read a scientific paper, but they like colourful charts where you can look at one country and compare it directly with the others. But the nice thing about this data collection was that it was timed specifically so that we had the very, very latest data collected just before the European Directorate for Quality of Medicines and Healthcare, EDQM, would meet. And that meant that we could actually put forward, based on our data, put forward the recommendations for haemophilia care for the Council of Europe. And most of those then were passed and they were put into practice. And what was nice there was we would collect the data from all the countries. We would use that data to put forward recommendations. Most of those recommendations would be accepted by the Council of Europe, which is 44 countries. And each country could then go back to their government and say, it's not just us saying this, it's the Council of Europe. So collecting data, using data cleverly to your purpose, but thinking beforehand, not just collecting data for its own sake, but think about what you want to use the data for and collect it in good time so that when you need it, you will have it. Thank you.
Thank you, Brian, for your presentation. Mainly, the prices are an eye-opener, the values that we are using for each of our countries. So I open the mic to all the questions that you may have for our participants. Any questions, any concerns? I want to ask the first, maybe as an icebreaker, maybe you can write it in the chat as well so that we can try to answer as many questions as we can. The main question would be, when it comes to cost for medication that you mentioned, Brian, what a paradox that the countries with uh, more economic development, they pay more for medication than countries that have lower incomes. The question is, when it comes to Latin America with our challenges, and when it comes to Ekawat's region, how can we move forward when it comes to lower prices? We know that there are regions that are going to change from night to day. We have a economic development that is different. How can we create therapies? How can we have more massive purchases, licitations, with to include more units, patients? What are the keys that you saw with your experience in Ireland and Europe that you can mention?
I'm doing a talk about this, a brief talk at the WPH CCS in Dubai in a couple of weeks. I mean, this is an area I'm very passionate about. I think a number of things. Um, in a fair world, the wealthier countries would pay the highest prices, the less wealthy countries would pay lower prices. The world doesn't work like that. I think a number of things. First of all, to me, it's really important that the key doctors and the patient organisation are formally involved in the procurement process. Now, they may be formally involved in some stages, not others, but I don't think we can abrogate our responsibility. You have to be formally involved. Secondly, knowing what kind of prices are out there. You wouldn't go out and purchase a car without having some idea what what other cars cost, what they cost in the next country. So why would you buy factor concentrate without knowing what the cost is in the countries around you? And I guarantee you, you ask the company who sells it, they oh we don't know that we don't have that information. Of course they do, but they don't necessarily want to share that. So the kind of data they showed there on the side, I think, is really important knowing what a reasonable price is. And I've seen countries say, "Oh, well, we've got emicizumab, we've got EHL factor, and we did really well. We got a great deal, and they're paying double what their neighbors are paying." So I think knowledge about price trends is important, and also I think one of the biggest problems with procurement is that you've got procurement officials and government officials and payers who won't or can't think outside the box. So they'll say, okay, in my view, if you want to procure hemophilia medications, you don't do it for 1 year, you do a contract for 2, 3, even 4 years. So you're buying a large quantity, you get a volume discount. But they would say, oh no, we always only do a 1 year procurement, and this is the way we buy medicines in the country. The way you buy paracetamol or antibiotics does not work for hemophilia. So effectively, you have to carve hemophilia out as an exception and have a different system. And I think looking very carefully at the criteria, looking at a multi-year tender, and making it very open and competitive so that the companies have to compete to get the business. That's really important.
Thank you, Brian. Tanya, you have you asked to you asked a question. Are you in the Spanish channel? Brian, tengo una pregunta. I have a question regarding emicizumab. In Brazil, the doctors use this medication when it comes to re when it comes to children and growing up.
See, so Brian, I'm sorry for this.
Okay.
This is what she's asking is the emicizumab vials come in different presentations, and that is provided by the doctors according to the weight of the person. Yes,
Yeah.
she's mainly talking about children. So what she's asking is if the if the sorry, the doses can be given in different moments. So she says that they are giving
Frequently.
it
Okay.
quarterly or monthly or weekly. So she's asking a little bit about that.
I know that in many countries, including the Netherlands, Cataline Fisher has reported that 21% of their patients are on a non-standard timeline. So in order to make sure you're using the full vial and you have no waste, for example, somebody who's on every second week, they might take it every 16 days to use the whole vial, or every 9 days, or every 5 days instead of seven. So you could adjust the timing to make sure that you don't have any waste, that you use the full vial. And quite a few countries do that.
So she's wondering whether it's advised to use all the vial, all the product that comes in the vial, and not discarding parts of it because of the weight. So that's the
I'm not going to give you clinic. I'm not a clinician, but my
yeah.
clear understanding is that unlike factor, like if you are supposed to take 1,800 units of factor eight and you get a 2,000 unit vial, you use the whole vial. You'd never waste the factor eight. With emicizumab, you're supposed to use a precise dose. So if they say you don't use the whole vial, you don't use the whole vial. The way you can use the whole vial is if you vary the number of days between the injections. And that's something that would have to be carefully worked out with the center director. So, for example, if there's some ME left in the vial each time after a weekly injection, you might say, okay, given the child's weight, if he takes it every 9 days, that uses the whole vial. That's an acceptable way to do it.
Okay, perfect. See? Okay, so she's grateful for your answer, and she's inviting you to come to Brazil on the 25th of November for the Together with Hemophilia in Brazil.
Thank you very much. I think November is already. I think it's pretty booked out already. Just let me
Okay.
check.
It's a busy year.
Well, possibly. I'm actually supposed to be doing an online strategic plan for a country in the Middle East, not the Middle East, in Asia at that point. But look, come back to me on that. Come back to me on that. But the other point about emicizumab, which is interesting, is that at the last two congresses, the doctors in India have reported using a half dose of emicizumab, which works very well for many people. And it gives you an idea as well of the variability in pricing. If I can give you an idea, and this is an extreme example, the price for a year's use of emicizumab for an adult varies from $650,000 in the USA to $12,000 in India for a half dose, which works. That's a 50-fold difference for the same product.
Hi, Byron. Uh, Dr. Ampaiwan, she just presented to the government. She used 1/4 of imicizumab
Hmm.
combined with the factor 8. So she can manipulate with the budget
Yep.
to
Yep.
use imicizumab,
Yep. Yep.
but that's only for the children.
Yep.
Perfect. Thank you.
Thank you, Tanya, for your question. Is there any other question? We have a few minutes left. Hello, I wanted to ask a question. We have Amanda. Amanda, you're in the English channel. You can switch to the Spanish one. Cesar, I understood that you showed in your charts that there was a decrease in the purchase of the factor, that it might be due to lack of reports of big countries that have not shared their data, or that we have emicizumab or any other different products. How do you think this will impact us as a community, this change in business? Because when it comes to industry, that we stop consuming factor, it's important to them. It's a very interesting question. There might not be an answer. No, we do have one. The question that Amanda is asking, when I talked about the purchase of factor 8, the lower purchase of factor 8, or any other product derivative from plasma, how could this impact? And we have a huge explanation. We don't have a definitive conclusion, but when it comes to analyzing the situation, is that since emicizumab entered the stage, there is a lowering in the purchase of factor 8. In the chart, we were seeing factor 8, and Brian explained it. It's the market. Roche broke the game when emicizumab came in. They changed the treatment for hemophilia. But about a week ago, the FDA approved efitusiran from Sanofi, and they have a medium extended life. Sanofi is playing with a recombinant product, and now they have this new product. So this will reduce the purchase of factor 8. That explains a little bit of to what showed on the chart. Does that explain it? Yeah, in Uruguay, we have a number of patients that is quite big when it comes to using emicizumab. We are trying to transition. We're trying to go through the third or fourth year with 80 patients using this, and we have seen an increase. We have seen an increase of factor 8. So they feel so well that they start doing activities that they have stayed away from. But it's interesting, since we are advocating, we still need the factor, because when something happens, we still need the factor. So even if with this charts and shows the changes of the market, when it comes to advocacy, and we spoke about this with Andres and Isabel, we need to defend the importance of having factor available to us. And I also wanted to add, the hardest part when it comes to being leaders in Latin America, it's important to try to deal with the half-life factor. which is different from the standard life factor. And we have equations that show a fair equivalence. So it will affect adherence to these sort of resources. We have an equation, and the same will apply for emicizumab. We have an equation so that the buyer can decide when it comes to just doing it while just considering the costs that the different pharmaceutics explains. So, Cesar, we have another question. We have Sophia, who asks, what sort of projection we have for the consumption of medication for women in Latin America? Will this data include us as well? No, like Brian said, I'm not a doctor, but we know it's not going to be treated as we're going to include the different situations that involve the patients. We have different products that will apply better for the use of women. So the buyer needs to provide the selection so they will have products for specific for von Willebrand and products that will be consumed by women more often. So when it comes to how come the global survey, what does it consider? Sorry, how does the survey consider the emicizumab when it comes to consumption? Knowing all that it's coming, all the therapies that are appearing, what's the challenge that is coming when it comes to consumption and purchase of these new therapies? Well, the shared decision making, even if they don't have a specific role for advocacy, it's a tool that we can use for advocacy. So this tool will become a tool for the patient and the provider. So what's your rate of bleeding? That's the way that we can see if the product is effective or not. Once the patient discovers, maybe some of you can see if they can see that there's no bleedings every single year, or there's only a bleeding once a year. There's something that we have to take into account. So there are other products, but he bleeds 4 or 5 times a year with those. So we have to treat the patient with what they want. In the annual global survey, we have included the emicizumab, and part of the task is to take into account that equivalence. So the people who send information to the survey, what is the value that we have for inhibitors? Sometimes the question may be very sophisticated when it comes to answering the survey. Sometimes they don't send that formula, that complete form, because they are afraid that they won't know how to answer it. So please ask your regional manager so they can help you and support you. Emicizumab and the molecules that will eventually come as well.
Can I make a point there as well? I think up to 5 or 6 years ago, you could track the progress of treatment in a country just by looking at the annual global survey per capita use. And as per capita use went up, you saw this is improving care. Now, that has now changed, of course, because you're no longer comparing like with like. So, standard half-life factor rate, there's a different paradigm when it looks at EHL factor 8. There's now a different paradigm again with Altuviiio, and emicizumab is different. With EHL factor 9, it's also different. But I think WH will be putting in these correction factors. We published a paper a couple of years ago. Group was led by Jeff Stonebreaker, showing that which came up with correction factors for EHL factor 8, EHL factor 9, and emicizumab. So the equation is that 1 milligram of emicizumab is equivalent to 70 international units of standard factor 8. And using that and the correction factors for EHL factor 8 and factor 9, you can actually compare like with like, because otherwise it's confusing. If you look at the European chart I showed you earlier and compare it to 5 years ago, you look at a country like Ireland, saying what's happening because the factor 8 and factor 9 are going down. Well, the per capita use is going down because we switched to emicizumab and EHL factor. So, and so now that the emicizumab question is sorted with the new correction factors, now we have marstacimab, concizumab, fitusiran. It's going to get very, very complex because I think per capita use is no longer the only thing you can look at from that point of view.
Perfect, Brian. Thank you for your clarification. We could still go on and continue with questions, but considering the time that we have for Brian and Asia and Latin America, we are going to close this event. Thank you for the space. Thank you, Brian. Thank you, Cesar. Thank you, Ekawat. It was a pleasure to have you and your expertise from Asia. And thank all of you who have participated. I was paying attention to the registry. We have a lot of people who participated. We have a lot of participants that had been in different events, and it's very important. And it shows commitment as a region to move forward. And thank you for your participation. Let me remind you that on Wednesday at 8 p.m. Argentina time, so this time, so we're going to have another talk when it comes to women and young girls. We have Dr. Rotolini from the World Federation, and we have Doña Coffin when it comes to data management for registry. When it comes to women, and the members of the coalition, they're going to bring us a more regional focus. You can register through Instagram, through the web, and we hope that we can see you there. Thank you. And greetings to everybody. We'll see each other soon. Bye.
Bye bye.
Bye.
Thank you.